Hello, friends. So let's talk about HLO-2 case histories. So as you can see, this page is from the specialty specific guidelines. So we will follow this because this is the most important document for your portfolio pathway. Now, I'm using the HLO-2 criteria for cohort 2. The reason is because cohort 2, as you know, that you have to show the maximum amount of evidence. And sometimes, even if you're doing cohort 1A or 1B, maybe the 10 case histories or 20 case histories may not be sufficient. So nobody is stopping you from adding more. So even if 10 case histories are a requirement for cohort 1A, you can submit 15 case histories as long as that that evidence is useful in demonstrating your ability to work as a consultant psychiatrist. So hence I'm using the cohort 2 criteria for a better understanding of what is required. And today we will run through the old age psychiatry case history requirements. Um, the points which are quite kind of very self-explanatory, I won't dwell much onto that, but if there are some tricky elements there, I'll talk about that in length. So HLO 2.1 communication, at least two case histories should include advanced communication skills through managing difficult conversations, trying to manage contradictory evidence, combining information from different sources, and managing conflict. This may include a second opinion where there has been a dispute about a patient's diagnosis. So in old age psychiatry, you may see where family are unhappy with the diagnosis of dementia, for example. So you see that a lot of times in your practice, especially when you're doing memory assessment clinics, where uh, family are of the view that maybe it's not dementia, it's something else. Sometimes there would be a second opinion coming from another doctor where uh, say a dementia diagnosis was given previously and you've seen the patient and you feel that the patient doesn't have dementia and you've reversed the diagnosis. And that also happens in clinical practice where you have reversed the diagnosis of dementia. So these are the things where you can get these two case histories from. Where the other issue is where uh, where there are some safeguarding concerns as well, and that is where you can include this. Although that you have to submit one case history which is purely related to safeguarding, so that also we will talk later. Uh, Full psychiatric history with mental state examination, you have to do this. And again, it has to be, you have to show variety of cases here, functional and organic. So uh, it has to be in different settings, obviously, but you have to show variety of cases. So when we talk about functional, you have to include cases of depression, anxiety, some personality traits as well, whether it is dependent personality disorder, a case of alcohol dependence or Korsakoff's maybe. Uh, you have to include a case of schizophrenia or schizoaffective disorder or both. Uh, so you have to include case of bipolar. So again, there could be other functional mental health disorders as well, but you need to ensure that you're showing variety of cases. Don't duplicate it. So say if you've shown bipolar, say maybe of manic type, don't repeat a case of another bipolar of manic type. Maybe you can include a bipolar of say depressive type. So you can include that. That is not a problem. But there has to be variety. If you've included schizophrenia, leave it schizophrenia, then don't add another schizophrenia case. Include maybe schizoaffective disorder, but in schizoaffective disorder as well, make sure you're showing variety. Schizoaffective disorder of depressive type or manic type or mixed. So you're showing variety of cases which demonstrate your skill of providing appropriate diagnoses. Then you also have to include cases with, say, where patient is on clozapine. Very important. As a consultant, you would be dealing with patients on clozapine. You have to include a patient with who is on lithium, and then you're monitoring that. Yes, you have to include a patient um, where you have referred that patient for ECT. So yes, that needs to be included. If you've got a TMS within your service, nobody's stopping you from doing that. Include that case in. So there has to be variety. When you think of the organic element, make sure that you're including a case of delirium, where there is significant physical mental health interface. You're including that. You're including obviously different types of dementia, um, Alzheimer's, vascular, mixed, frontotemporal. And when you're doing the assessment, make sure that you're including every element. You're taking a history, you're taking a detailed collateral history in cognitive assessment. Uh, you have included other disciplines as well, where the OT is doing functional ADL assessment related to cognition. Maybe you've sought help from psychologists, from neuropsychologists who've done their assessment as well. So you're collating all that information and arriving at a diagnosis. And if recommended, you're starting anti-dementia medication. But then again, that's where the role of biopsychosocial formulation is, where you have delivered the diagnosis, but that's not the end. Uh, what is the post-diagnostic support? So the post-diagnostic support doesn't include just medications. You have to advise about lifestyle management. There is a discussion around advanced care planning, uh, informing maybe the DVLA, then referral to Alzheimer's Society, referral to cognitive stimulating therapy and the social activities, social groups for cognitive stimulating therapy or cognitive stimulating activities. So you have to include everything there. Uh, this one, which I want to emphasize, differential diagnoses. Uh, so when you're doing an initial assessment, it is difficult to establish one particular diagnosis. But it's good that if you're showing variety, where you've done the initial assessment, say if a patient is in an inpatient unit, you've done the initial assessment, but at this point in time, you exactly don't know what's going on. So you've given your diagnoses, say uh, recurrent depressive disorder, severe with psychotic symptoms, or then you've included delirium there, maybe hypoactive delirium. This is just an example, but you're mentioning differential diagnoses here. Uh, uh, then you're including cognitive impairment, but maybe further assessment is required. So you're including different differential diagnoses initially, but then as you progress with the case, you start some treatment, you start the assessment, then you can narrow the diagnosis down, and then at the time of discharge, you're giving a final diagnosis. The final diagnosis sometimes may not be just one, it could be two. So that's fine. But having that variety where you have explored everything there. So say, for example, this is just a hypothetical example where the depression was actually mainly related to hypothyroidism. So you've included that. If you have included that in your differential diagnoses, and then you can follow it up. Say uh, there was post-ictal confusion. Maybe there was delirium secondary to epilepsy. So you're seeing post-ictal confusion. Was there a development of post-ictal psychosis at that point in time? So you're including many differential diagnoses there. So you're including such cases with appropriate or comprehensive differential diagnoses. The other organic cases could be a presentation which is related to Parkinson's, or maybe organic psychosis, or as I've mentioned, post-ictal confusion or psychosis. You can include uh, other organic conditions like Huntington's, if you're able to find any in your caseload in your clinical practice, or CJD, or early onset dementia. That is part and parcel. So you include that dementia, different types of dementia. Very important that you include frontotemporal Lewy body dementia and Parkinson's disease, along with Alzheimer's vascular or mixed. So you're including all of that. There could be a diagnosis of organic personality disorder. There could be a diagnosis of multiple system atrophy. So all these cases have to be included. You have to show the variety of cases there, right? It doesn't matter which cohort you are under, but like you have to show that ability to assess patients in depth. There has to be, physical mental health interface cases. When you're doing memory assessment, make sure that you're including appropriate assessment tools, whether you have used ACE3 or whether you've used mini ACE because of your poor engagement, or maybe sometimes you might have used RUDAS. So make sure that you're including all that, and highlighting the positive findings, whether any investigations you requested, whether it was a PET scan or a SPECT scan or DAT scan or even MRI. So that needs to be captured. So it's mentioned here there should be at least two examples of continued work with the patient. Initial patient history followed by subsequent reviews which show management of complex clinical journeys. What I would suggest is maybe submit more than two, uh, maybe five or more. And if you can, so most of the cases which you submit, make sure that there is a clinical journey there, right from the beginning till the end, initial assessment, follow-ups, and then discharge. So that would be ideal. So I would suggest it should be easily more than two where you're showing full cases. And then again, I mentioned about the differential diagnosis, physical health issues, medication interactions, anticholinergic burden, polypharmacy cases. Uh, in fact, in most of my cases histories, I've included the ACB, the anticholinergic burden score as well. So make sure you're doing that. So see, as I've mentioned, at least 5 cases of total 30 must demonstrate complete full physical health examination. So again, when you're reviewing a patient from the beginning till the end, and especially in old age psychiatry, you would have done some sort of physical health assessment. So again, make sure that you're doing this if you can do in majority of your cases where you're doing a full assessment from the beginning till the end, and you're doing a full physical examination. More the merrier. And then uh, at least 3 cases of working across interfaces. You have in old age psychiatry, sometimes you liaise a lot with the neurologist because there is a lot of overlap in the clinical presentation and diagnosis. So you're capturing that you have referred patient to neurologist or maybe geriatrician, or even other specialties for that matter. So whether it is medical or non-medical, it's about whether you have picked those key physical health signs, or some even like you can send your referral letters to the radiologist. So say you are in a memory clinic, or you've seen a patient in CMHT where you suspect there are significant signs of cognitive impairment, and you want to go for any radiological investigation. You're writing a referral to the radiologist that you would like to get an MRI or PET scan done. So when you're doing a referral letter, you're being very comprehensive there, that what exactly you're looking for in that scan. So whether it is any atrophy or any small vessel changes, or uh, any hyperintensity, hypermetabolism, if it's a PET scan. So if you're being very explicit there, that creates a good impression that the evaluators know that what exactly you're doing, what is the rationale behind these referrals. One of the most important evidence is the your psychotherapy cases. So I gather that in cohort 1A and 1B, you don't have to submit the summaries and all. But again, I feel that if you do it, I think it's important that because I don't think there is any other way you can demonstrate your ability of a better understanding of psychotherapy modalities. So it's good that you're submitting your psychotherapy cases irrespective of your cohort. But in cohort 2, yes, psychotherapy cases are required in two different modalities. Again, it doesn't necessarily have to be one long case, one short case. It can be two short cases, two long cases, as long as these are different modalities, whether it is one CBT, one cognitive stimulation therapy, or but if you're submitting old age cases, it's mentioned in the guidelines. At least one case should be regarding a person who is within an older adult service. So again, whether it is cognitive stimulation therapy or whether it is any other modality, but one out of those two cases should be uh, in the older adult services. It has to be an older adult case for your psychotherapy. It could be any modality, CBT, cognitive analytical therapy. One of my psychotherapy cases was cognitive analytical therapy. Um, could be anything, compassion focused therapy, bereavement counseling, uh, uh, CBT, of course, psychodynamic, interpersonal therapy. It could, but it has to be two different modalities. It could be group, it could be one, an individual, one-to-one. But here, secondary evidence is important, where you have to submit a supervisor report from your supervisor. So in psychotherapy, it has to be either a consultant medical psychotherapist or it could be a senior clinical psychologist in the team. But it has to be very senior. I think above band 7, I think, but it has to be a senior clinical psychologist who is supervising you during the assessments and writing a supervisor report or testimonial and completing the relevant workplace-based assessment for psychotherapy cases, whether it is PACE or SAP. But here you need secondary evidence along with your psychotherapy. Now, in psychotherapy cases, you have to do an initial assessment, a thorough initial assessment. You're submitting summaries of the sessions you have done. So say if you've done cognitive analytical therapy, you have to do the sequential diagrammatic reformulation chart. You have to write the initial letter and then the goodbye letter. You're including summaries of every sessions you did. So you do 16 sessions at least in cognitive analytical therapy. So you have to should document every summary during every session. So again, that has to be very comprehensive. Even if you're doing groups, you have to include the summary of what you did exactly in those sessions. So again, that primary evidence is required. So it could be, as it's mentioned here, case summaries, patient letters, or descriptive write-up, which include assessment, formulation, and actual sessions delivered, conclusion, and follow-up. So as you can see, I've already mentioned polypharmacy, comorbidities, multiple comorbidities, um, at least two cases of total 30, variation from established care pathways where clinically indicated and justify these decisions as needed. Variation from established care pathways. So again, it could be a referral to any medical specialty. Uh, say this is just to give you an example where you feel that patient came with anxiety and depression, but the core symptom was pain. For example, there was chronic pain, maybe fibromyalgia or chronic fatigue syndrome, which was the root cause of the anxiety depression. You refer that patient to the pain specialist, for example, or to pain clinic, so that you can include that history where there is significant physical mental health interface, and you've done a comprehensive assessment and you've referred patient elsewhere. So that is something which you can use. You have to show, as it's mentioned here, at least two cases that demonstrate an understanding of individual variation and the impact of social, cultural, religious and spiritual factors, including effects of deprivation, discrimination, and racism. So two cases of, two diverse cases in a way. So again, diversity doesn't mean only ethnicity. Uh, you have to include cases where somebody, yes, with a different ethnic origin, with different culture. So the cultural element plays a huge role in our practice. You include the religious element there, but you also include other, diversity, maybe whether it is related to sexuality, sexual orientation, any disability. So that is how the diversity is. It's not really about race or ethnicity, it's about any disability or sexual orientation or sexuality. And also, you make sure that you're including two such cases where you're demonstrating your ability to handle cases as a consultant. Uh, in diverse cases or variety of cases. Uh, Again, this is very self-explanatory how you organize the evidence in a bundle. So again, if you can't submit all the cases in one bundle, you can divide it, but make sure that the label you've put on that fold on that file is mentioned in your verification form. It has to match. If they don't match, they will return that evidence to you. So say if you're submitting 20 cases, so maybe you can't fit all the 20 cases in one folder or in one file. So you can have, say, maybe four files of five cases each, and you're labeling that file, and whatever name you've given to that file, that same name should be in your verification form. Uh, so make sure that you bear that in mind. And the things which have changed is last 10 working years. So that's a good thing that you can submit your cases from the last 10 years, working years, of course. Now, uh, triangulation in terms of including your reflections or workplace-based assessments or minutes of the meeting. So say if you're dealing with a complex case where you're having difficult conversations either with the patient or family or other teams, there would be minutes of those meetings. So you're including that and make sure that you're anonymizing all identification details. But that minutes where it could demonstrate your active role as a lead or chairing, or you've chaired that meeting, make sure that you're including that to triangulate that evidence along the minutes of the meeting along with your comprehensive case history. And you can add a reflection or a workplace-based assessment to triangulate that evidence. It has to be real world settings. So the GP letters you're sending or the tribunal report, everything has to be real world primary evidence. So yes, I know the GPs, they don't like long letters, but I think it's important that you're doing very, very comprehensive letter for your CESR, for your portfolio pathway. So yes, do your GP letters and submit those GP letters, anonymize it. I think better to anonymize the surgery name as well, because that is also one of the identifiers. Um as I said, mentioned already, tribunal manages panel reports and medical legal reports. Section 49 you're doing sometimes, so that could be a good evidence, but every evidence has to be primary. When you're doing, when it's an inpatient, yes, the manager's hearing of the tribunal report does help with that. But you can, so when you're doing any records on the electronic system, so you can use that as well as primary evidence, as long as you've taken that uh, from the electronic system. So make sure you're anonymizing that, so you can use that as well. You can use discharge letters as long as it demonstrates that you've taken a lead role in it, because sometimes discharge letters can be written by resident doctors and specialty doctors. So what you've done as a maybe a senior doctor who is working towards consultant role. So when you're doing a discharge letter, maybe if you're working as a specialty doctor, you've put a lot of element there, but that has to be mentioned that it is something you. So maybe you can do the discharge letter. Say Dr. Jamali, specialty doctor two, the name of the consultant. You're doing the discharge letter in it, and you're doing a detailed discharge letter to the GP, and your consultant is doing a workplace-based assessment for that. That is fine, but don't submit many discharge letters. Maybe one or two, not more than that. So doing but again, all these evidence, it has to be primary evidence. So I'll stop here, and then we'll talk about other evidence as well in the future videos. But thanks very much for your time. I hope it was useful. If you've got any questions, feel free to put that in the comment box. I will respond to that as soon as I can. Thank you very much. Take care. Bye bye.